Assalamu alaikum, everyone. We are going to start our session of imaging and oncology. And I'd like to introduce our chair for this session. Our first chair for this session is Dr. Professor Shahid Waheed. He does not need an introduction. He's a renowned radiologist, passionate teacher, a senior CPSP examiner at CPSP, and he has over 30 years of experience in radiology. He's currently working as a professor at Al Noor Diagnostic Center. I'd like to welcome you, sir, as a chair for the session. Our second chair for the session is Dr. Anisur Rahman. He's a consultant radiologist working for over 10 years at Shaukat Khanum Memorial Hospital. And he is the head of teaching activities at the radiology department at Shaukat Khanum. I welcome you, sir, to join us as a chair. So the first topic for our this presentation will be refining residual disease assessment and localization in the post-chemotherapy breast. This will be by Dr. Sarfraz Ahmed. He's a consultant radiologist currently working at Blackpool Trust Hospital with a subspecialty in breast imaging. He has many published peer-reviewed journal articles. I welcome you, sir, to start our first topic.
Thank you for the introduction, and thank you, Shaukat Khanum, for the invitation. And the slides go down. Your lights too. So basically, we are discussing residual disease localization and refining disease assessment in post-chemo breast. Basically, these are like two large subjects. So today's talk will be focused on localizing residual disease in post-chemo breast. So I will just give you quickly background. So with advancements in new adjuvant treatment, there is now more emphasis on breast conservation. Breast conservation basically involves the removal of cancerous tissue while preserving as much of the breast as possible. This poses challenges to accurately localize breast lesions in post-chemo breast. Residual non-breast lesions in post-chemo breast require image-guided localization prior to surgery. Now, accurate localization is crucial for successful surgical outcome. So, success of surgical outcome is mainly measured by two indicators, negative or positive surgical margins or re-excision of margins or re-excision rate. So just to clarify what does it mean when we say margins are involved or not. So this diagram simply just explains this concept. So this is a surgical specimen. These are the margins of the specimen, and we can see this is the cancer. So there is like a healthy breast tissue between the margin and the cancer. So we see there is no cancer cells, and there is a healthy breast tissue between the margin and the cancer. So this is called negative margin or clear margins. The other slide, you can see there is cancer at the margin, and we call it positive margin. And this is very important in order to predict the prognosis of surgical outcome and the future treatment planning for our oncology colleagues as well. The surgeries which have positive margins, basically these patients, they require re-excision of the margins, and then they are at higher risk of developing local recurrence and distant disease as well. So keeping this fact in mind, we need basically localization techniques which help the surgeons to have, to pinpoint the area of cancer so that we have more negative margin surgeries than positive margins. And most guidelines recommend there should be minimum tumor-free distance of 1 millimeter from the margin for either invasive disease or ductal carcinoma in situ to ensure optimum oncological outcomes. So in order to achieve these results, breast localization needs to rely on techniques which provide pinpoint and high level of precision. Now we all know wire-guided localizations has been well established and most widely used in still many countries, but now they're being replaced by newer wireless techniques. So this is an example of typical wire localizations. There are many known disadvantages. Wire localizations have several disadvantages: wire transaction, migration, decreased flexibility, scheduling the procedure, reduced operative room efficiencies. It needs coordination between radiology department, the surgical team, and the surgeons and the OR team. Patient discomfort. You can see the wire is sticking out of the breast, which is not very comfortable for the patients, and it adds to the patient anxiety. Sometimes suboptimal surgical incision placements due to wire location. Potential delays in theater time or theaters running over at the end of the day. Increased excision rates and suboptimal cosmetic outcome. Now this disadvantage is of paramount importance because you want surgeries which have less re-excision rates in order to have good surgical outcomes. Increased re-excision rates, they are not um, beneficial either for the surgeons or for the patient. So there are like newer techniques. These techniques can be divided into two parts, radioactive and non-radioactive. Radioactive techniques, again, this is like radioactive seed localization and radioactive lesion localization, which is called ROL, and radioactive seed localization is called RSL. So non-radioactive techniques, we have magnetic seed localization, punctuation seed localization, non-radioactive radar localization, which is also called Savi-Scout localization. Then we have radio frequency identification tag, and then we have hematoma ultrasound localization. So radioactive localizations, I will just quickly go through these. These are also not in not many trusts in UK, they use these techniques, so they are moving towards non-radioactive lesion localization. So this is radioactive seed localization. We use iodine-125 radioactive seed in a titanium capsule, and which emits gamma radiation. And during surgery, the seed or lesions are localized using a gamma probe set for iodine-125. Radioactive seed localization, we can also combine with technetium-99 isotope used for sentinel lymph node biopsy. And surgeons can basically, differentiate between iodine-125 activity and technetium activity by altering detector settings. So this is a typical radioactive seed apparatus looks like. So this is the titanium capsule, and inside is the radioactive iodine-125. Then we have Geiger-Müller counter. This is the delivery system, and this is how it looks like on a surgical specimen. It has some advantages. You have scheduling flexibility. Half-life of iodine-125 is about 60 days. There's no external component, no depth limitation, compatible with sentinel lymph node mapping, better cosmesis. There are disadvantages. We have Dr. Humayun here, and he knows that radioactive material in UK, we have very tight, very strict radiation exposure, sorry, regulations and safety precautions. So that's why this is not used in many trusts in UK. So, sorry, I have a bad throat. So, radioactive seed localization versus wire localization. So there is many papers have been published which showed that the radioactive seed localization is better when it comes to the negative margins. If you remember, we discussed this slide earlier, which shows what does it mean when we say negative margins. So overall negative margins in radioactive seed localization is 70 to 93%. And 43 to 95%. There is a small difference, but still there is a difference. So radioactive seed localization is a safe, effective procedure, but as I discussed before, there are like radiation safety precautions and logistic involvements and issues. So next is radioactive occult lesion localization, which is called ROL. It is more or less, another technique which is based on radioactive material. In this case, we use technetium-99 labeled HSA, human serum albumin. So I will not go into detail of this. We have already discussed radioactive seed localization. Advantages and disadvantages are more or less similar. Disadvantages are main radiation exposure to patient and staff and radiation safety precautions. Now I'll go to non-radioactive localizing techniques. So we'll discuss first non-radioactive radar localization, which is also called SSL, Savvy Scout localization. So basically this involves non-radioactive microimpulse radar technology to provide surgical guidance. The system consists of an implantable 12 millimeter reflector, which comes in a 16 gauge preloaded delivery needle, a handpiece, and a console. The reflector consists of an infrared light receptor, resistor switch, and two antennae which placed into or near the target through a 16 gauge needle. It can be deployed under mammogram or sonographic guidance. The handpiece and console system emits pulses of infrared light and radar wave signals and receives signal back from the reflector to provide real-time localization and target proximity information to the surgeon. The reflector is FDA approved and CE marked for long-term implantation. I will just show you in next slide what it looks like. So this is the Savvy Scout, and this is in the center is the body. It is called reflector, and then we have two antennae on either side, and it comes in different lengths. Preloaded needle, 5 centimeters, 7.5 or 10 centimeters, 16 gauge needle. This is the handpiece and console system. And this is how it looks like on ultrasound. It's quite echogenic and can be seen under ultrasound easily. And this is a post-deployed check mammogram, and you can see this reflector, and this is surgical specimen. Now the advantages, it gives you scheduling flexibility. FDA has approved it for long-term implantation. It means this can be deployed at time of biopsy as well. So this decreases patient visits to hospital. Like if patient is going for neoadjuvant, normally what happens, after biopsy, you have to put a clip. And this means patient will have to come back to have a clip. And then after neoadjuvant, patient will come back again to have this, what we call it, localization device deployed in order to be removed at time of surgery. But this Scout can be deployed at time of biopsy, and then patient doesn't need to come back again for another procedure. And once new adjuvant treatment is done, they can go back straight to surgery. So there is no radiation exposure, no radiation safety precautions, bad cost message. Disadvantages is definitely costly. There are depth limitations. Any tumor which is more than 6 centimeter may be difficult to detect. You can't reposition it once deployed. Post-biopsy hematoma can interfere with signal. No MRI compatible needle delivery system, interference with older halogen lights in operating room. It does contain nickel and there are possible nickel allergies. There is limited published data yet. Now we use this in our hospital and uh, we have deployed many in many patients. The overall results are good, but this is one of the absolute contraindication. We came across few patients who had nickel allergy, so we had to postpone their device deployment and we had to utilize other devices. Apart from that, we had a good experience with the service code localization. So again, service code will be compared with the wire localization. So there was a study done by Patel et al. And they showed that the negative margin rate with service code was 92.9% versus 88.1% in wire localizations. And the re-excision rate was quite low when they used service code, which was 7.1% versus 9.5% in wire localization. So next is magnetic seed. So magnetic seed is one of the most widely used device, localizing device at the moment in UK. This is how it looks like. It's quite small seed. It's about 5 millimeter in length, and it's like the size of the grain of a rice. So we are basically, switching from Saviscout to mag seed. It's only because we have some trusts which use mag seed, so we were trying to have similar sort of devices at different trusts. So a business case has been approved. Basically, how it works, there is magnetization of the seed containing a magnetic iron alloy to localize the lesion. This system consists of a stainless steel seed which comes preloaded in an 18-gauge needle introducer and a detector probe centi-mag. I'll just show you how it looks like. So this is the seed. It is made of medical grade steel. It has nickel, but it's very low compared to Saviscout. And it comes preloaded in 18-gauge needle. It is FDA approved as well for FDA and CE marked as well. And it has been approved for long-term implantation as well. Like Saviscout, it can be used for long-term implantation and you don't need to put a biopsy clip. When you do a biopsy, you can put this straight into lesion. And once new adjustment is done, a patient can send back to surgery directly. So this is the whole system, how it looks like. So this is mag seed, this is the delivery needle. This is called console and centi-mag. This is the surgical, this is post deployment check mammogram, and this is surgical specimen. So what are the advantages? Scheduling flexibility, as we know, it can be placed well in advance. Unlike wires have to be placed on the day or day before, but these Saviscout and Mac seats, they can be placed like weeks, months, or now even for months as well. There is no external component, no radiation exposure, no radiation safety precautions. This is stainless steel. The manufacturer says no issue with nickel allergy, but it has small component of nickel. So, but still, I think patients with nickel allergy, they can, Maxid is an alternative to Saviscout. The better cosmetic outcome, uh, contra count indicates distance to the seed. Magnetic seed provides a point source which enables continuous reorientation during surgery. Seed can be detected in deeper lesions, very low re-excision rate, and the MAG seed are CE marked and FDA approved for long-term implantation, as I said before. So disadvantages, cost is a big disadvantage. So compared to wire, which is like, if I say in pounds, wire usually cost about, I think, 30 to 40 pounds. So this is around 250 pounds. So cost is a big disadvantage. Potential depth limitations in large breasts. If the lesion is deeper in the breast, sometimes it is a struggle to locate them or detect them. No repositioning once deployed. They are not MRI compatible needle delivery system, and need for non-magnetizable surgical instruments. But the manufacturer says the new Centimag Generation 3 partly overcomes this issue. MRI bloom artifact with older magnetic seeds was 4 centimeter, but now with new Maxit Pro, it is far less. So this is the newer version, which we call Maxit Pro, as I already said. This is an Endomag product with older Maxit. The detection was up to 3 centimeter, but with new Maxit Pro, you can detect the tumor up to 45 millimeter. MRI artifact is 96% less. So this is what it looks like on surgical specimen and post-chemo. This is how it looks like on ultrasound. And this is the movie when the surgeons, they can pinpoint the area. And this is called Centimag probe. And this is the console. And you can see these numbers there. The numbers which are higher in position, it means they are like pinpointing the area and they are directly over the lesion. And this is very helpful. And this is margin sensing, as I said before, margins involvement. This can give you an idea whether the max seed is closer to the margin. It means surgeon can go there and then directly to remove further area and shave the area around. So magnetic seed is a feasible means of localizing breast lesions, and up till now, I think most widely used, about 350,000 patients have been uh, in 350,000 patients max it has been deployed. So thank you so very much. So these were basically two major techniques, scout and magnetic seed, which are being widely used in UK at the moment. The other techniques, they're not used widely, and there is limited published data on those. Thank you. Any questions? Adam. All right, thank you.
Thank you, sir, for the comprehensive talk. Our next topic is precision imaging in women's imaging current perspectives, and the speaker will be Dr. Mohammad Ramzan. He's a highly qualified consultant intervention and diagnostic radiologist working at Pakistan Kidney and Liver Institute. He has previously worked at NHS as a consultant for many years and has done fellowship in intervention radiology from Imperial College London. So I welcome you.
It's not Imperial College, it's Guys and Thomas, actually. Thank you. So my talk is not about the imaging, actually. It's basically the intervention. It will be combo of benign and malignant diseases, actually. And what we can treat in women, actually, that's the main topic. What exactly? So it's a bit different from the main concept. So the pinpoint precision advancing in women health with intervention radiology, actually. Intervention radiology is a minimally invasive. We can offer and it has evolved over the decades, and we can offer a lot of minimally invasive procedure for both benign and malignant diseases as compared to surgery as an alternative, and with a shorter recovery time, low complication rate, and improve the woman health. So this is what exactly is historically. The resection has a high mortality and recurrence rate, and endovascular therapies has emerged as a less invasive alternative with comparable efficacy. So the IR can give minimally invasive procedure, quick recovery, low complication rate, minimal or negligible pain, no scars, and treated on a daycare basis under local anesthesia or sedation. So what exactly we can offer in a woman health kind of things? So the main thing what we treat is, the most common thing is the fibroid. We can treat adenomyosis, endometriosis or endometriomas, fallopian tube recanalization, pelvic congestion syndrome, postpartum hemorrhage, and morbid adherence of placenta like placenta increta or percarita, breast tumors, oligometastasis of gynecological and the breast malignancies, biopsies, drainages is the main thing. We also do IV access like Portacath and tunnel lines for chemotherapy, and we do palliative procedures. This is the first thing is fibroid embolization, actually, or fibroid treatment, I will say. So in fibroid, we can do either the uterine artery embolization, we can do ablation using radio frequency, microwave, or even the cryoablation and coablation, which is famous in the town in these days. And we also use and HIFU. It's a highly focused ultrasound. That's a very good thing, actually, because it's not invasive. So again, we preserve the hysterectomy, and we can treat the infertility. Hospital stay is 1 day or even shorter, and it's a rapid recovery. These are the particle we use actually for the embolization. So this is a typical example. We can see the catheter is in the uterine artery, and it's embolized. This is a typical the blush of the fibroids, which we see before embolization. And these are some of the videos. So how it appears before embolization, you can see on this side, and how they appear after embolization, the complete stasis in uterine artery. So these are static images of the same patient. Sometimes video doesn't work, so that's why I have the static images. There's another case of fibroid embolization, catheter in. It's a pre embolization, and then is the post embolization complete stasis. Same. So how these appears on follow-up, actually, you can see the MRI on this side. This is the pre-embolization. Not really sure something is there. नजर ही नहीं आ रहा है. Okay. So this is the pre-embolization, and you can see on the post-embolization follow-up, the fibroid is completely cystic and it's not enhancing. You can say the success rate is more than 80%. It's comparable with surgery, and you can save the uterus. We can do fibroid ablation. This is the fibroid It's the pre-ablative ultrasound, and this the post-ablation. We have done microwave ablation. So in these cases, we do at multiple. This is not a very ideal in large tumors, because if these, even if you leave a very short thing like few centimeters of the lesion, they will grow in time. But you can have immediate relief symptoms and can have the fertility kind. So HIFU is a really good. This is a pre-treatment, and this is the follow-up ultrasounds of a patient like HIFU. HIFU is a highly focused ultrasound, actually. So this is done percutaneously. We don't use, actually, it's not available in Pakistan, but in UK, I think the couple of centers are doing that. So it's like using the probe, you're using the focus beam like any radiation, like SBRT, a gamma knife, and the focus is the fibroid, and you can treat without any incision, needle insertion, or anything like that. Adenomyosis is a difficult thing to treat, actually. We can do, in these cases, uterine artery embolization, and success rate is more than 70%. We particularly use small particles in such cases, and the outcome is really good, because in the past, the people were offered hysterectomy in such cases, actually. So pelvic congestion syndrome, another thing which the females come across, is a chronic pain, actually, and it's similar to the varicoceles, actually, in males. So we use different materials like foam. These are the coils. We can use glue brand for this, whatever you want to use, and this is the typical way we do, actually. So this is the ovarian vein, and these all coils are put in. You can even input the glue in, and you can treat the pelvic varices from the internal iliacs, or the vulval varices. They are sometimes really have a lot of discomfort using embolization materials like STS is really good. Morbid adherence of placenta, that's in placenta, especially in Creta and Percreta. This is a really challenge for the gynecologist to deliver these patients, actually, when the placenta is going beyond into the muscular layer, or it's going across. So what exactly we do during the surgery, we put the balloon in the internal iliacs, both sides, and we inflate and deflate. The cycle is 13 into 2, actually, 13 minutes inflation and 2 minutes deflation. There is a new technique, that's Ebola, that's the distal aortic balloon, actually, that can be inflated in the infrarenal aorta, and you can do the similar thing, actually, and that's very easy. Even you can do without fluoroscopy, actually, because there are certain markers on that. So that has changed the whole thing, actually. So AVM is another thing which come across, and the patients can present in pregnancy either with bleeding or postpartum bleeding, and this can be a very disastrous bleeding. So we can embolize and preserve the fertility of the patient using, I normally use glue in these patients, but we can use onyx. Onyx is this, but it's a very expensive thing, actually. So this is a very typical example. You can see this is a arteriogram, and you can see how it looks like this AVM, and I have embolized with the glue, actually. If you can see on the other side, it was plied from the other side, and this all glue into the artery. The patient had, you can say, the pregnancy after 6 months, a year, and she is doing fine. There's another example of typical AVM and embolization of AVM. This is uterine artery embolization for AVMs. A fallopian tube recanalization is another procedure which can be offered. It has approximately 35% success rate of recanalization. So we can use like catheters, go in and try to open the both fallopian tubes. This is how the things work, actually. So this is a typical case where the tubes are blocked here. We went in one side, and then we had the both sides open, and there's a free spillage of contrast. Endometrioma is another difficult thing to treat, actually, especially when you do surgeries. There's a lot of adhesions. Patient can end up having infertility. What exactly we can offer? This is not for every case, keep in mind. These are selected cases where localized lesions, post-surgery things, or even a localized lesion which are accessible percutaneously. So what exactly we do, we put the needle in and we aspirate whatever we can do, put some ethanol in, wait for 5-10 minutes, and we remove the alcohol. We can do in a limited size endometrioma like cryoablation or microwave ablation instead of doing like surgery. So the results are really good. This is one of the case actually. So what we did actually, we went in, put the drain in, contrast in, then alcohol in for 10 minutes, and we aspirated everything at the end, and the patient really did well at the end. Breast tumor, I think, Sarfraz has said a lot about. We do biopsies, clipping, and we can do ablation, especially in benign breast lesions and very selected cases where nothing can be offered, but we can treat like even the carcinomas localized to the breast. This is the typical biopsy needles. This is how the biopsy is done. Clipping is already discussed a lot. I will not say anything. But we don't have fancy equipment here like you, Sarfraz. And as I said, we can do cryo, micro, or radiofrequency ablation for benign and some selected cases of malignant tumors. This is one of the example of tumor ablation. This is the RFA of a breast lesion. This is the lesion actually, and this is how it appears on, and this is the needle here. Oligometastasis is the one thing which we can offer, and up to 3 or 4 metastatic lesions in the liver, when the chemotherapy is not working, we have exhausted everything, we can offer treatment. And the treatment options are either ablation using any kind of or radioembolization or TACE. Radioembolization is coming up with time as a main thing to treat the oligometastasis, especially in liver. So we can offer, and these things are, so RFA, as I said, we can do TACE, we can do radioembolization, we can do hepatic artery surgery. I haven't done this before. And we can do like palliative procedures, like where the metastasis has compressed the biliary system, we can do biliary drainage or stenting, whatever. So this is one of the example. This is the patient who had the liver mets, had chemotherapy, and it was not really responding well. It was really difficultly, and if you look at, I'm coming from the side through the lung into the liver actually. So there's not accessible percutaneously from the other side. So we went in through the lung and we ablated the lesion. This is the lesion post ablation actually, and it's nicely done. No enhancement is over there. And luckily we had no pneumothorax. Sometimes you have to take the calculated risk. Even in this patient, if I had a pneumothorax and you're treating the cancer, doesn't matter actually. The pneumothorax can be treated. So this patient really did well, and then she was on maintenance chemotherapy. This is another case of similar like oligometastasis. This is the patient who had the single mats in the rib actually. So the surgeon was keen to excise this rib, but this is really vascular. They want to embolize before. So we went in, this is the lesion here, and we embolized before surgery, and this was the post-embolization. This is the same patient. We can do bone biopsies and the CT guided. This is the typical example. This is not, this is something which is cosmetic actually. We can do like, especially when you are going for the incisions on the neck these days, it's a very important not to have for the like incisions. So we can offer for the benign lesions, like we can offer microwave ablation, and how it appears, this the thyroid nodule. This is how the microwave is done, and this is at the end the result of microwave. So everything is gone, so no scar, nothing. So it's something which we use for cosmetics. This is another example of microwave ablation of the thyroid lesion. So palliative procedures like in obstructed kidneys, we can do like nephrostomy insertions. We can do pain management like blocks and we can do tumor embolization where the tumor is stretching and causing pain. So it improves the quality of life of the patient. So these palliative procedures we can offer, and also the drainages and ascites drainages and this kind of stuff. This is how we do portacats and like line insertion for chemotherapy. So this is the venous access thing. Do like drainages, ascites drainage, and especially in pelvic inflammatory disease, like pelvic abscesses can be drained percutaneously using CT or ultrasound guidance. This is one of the example where there is an abscess in the pelvis with air fluid level, and the drain is placed through like anterior to the iliacus muscle and behind the like colon. So you can see the drain is placed. These patients really respond very well to the drainages. It's last not but least, hemorrhoid embolization or superior rectal artery embolization. We can offer, and we do superior rectal artery embolization, especially in cases where the routine treatments don't work normally. And in our circumstances, the patient doesn't want to go to the surgeons to have this kind of surgery. So this is the superior rectal artery, and we can embolize the superior rectal artery, and hemorrhoids really respond very well. I preferably use glue or coils, and this is a very typical example here. There of the embolization, we have done it. This is how we do, and the superior rectal artery is embolized, and they really do really well after embolization, and you don't need to have the perineal, or you can say anal surgeries and this kind of stuff. So it's a very neat and clean procedure. So taking my message is radiology can play an important vital role. Intervention radiology plays an important vital role in workup, treatment of benign and malignant conditions leading to continued improvement of women's health. Multidisciplinary approach is very important, especially to select the patient in which patient is suitable for such and such treatments, because we are going beyond the guideline. And it offers targeted therapies to achieve the local tumor control, enhance survival, preserve quality of life. We also offer lung tumor ablations if there's a couple of metastases, liver and bony metastases up to a certain number. So especially in patients who have exhausted the other options, treatment options. Thank you very much.
Thank you, Dr. Ramzan. Our next topic will be radiological evaluation of reconstructed breast and cancer patient by Dr. Sara Rahman. She's a consultant radiologist at Shaukat Khanum Memorial Hospital, and she has completed National Breast Imaging Fellowship from UK and has extensive experience in breast imaging and intervention. Dr. Sara. Thank you.
Assalamu alaikum. Thank you, Dr. Akam. I'm Dr. Sara Rahman, radiology consultant in Shaukat Khanum Hospital, and today I'm going to talk about imaging findings in breast cancer patients with reconstructed breasts. I have no disclosures. So since the advances in breast cancer survival, reconstructive surgery has become an integral part of patient care. But sometimes it is difficult to differentiate normal postoperative findings from other complications or recurrence. So therefore, in this talk, I'll be focusing on the three key areas: normal postoperative changes in the reconstructed breast, what is expected and how it looks on the imaging, what are the suspicious findings that need further workup to exclude breast cancer recurrence, and various early and delayed implant-related complications. So the various treatment options given to breast cancer patients include breast conservation surgery that involves excision of the tumor with a normal rim of surrounding breast parenchyma while conserving patient's breast appearance and form. And when breast conservation is not possible, either due to extent of disease or multicentric disease, then mastectomy is done. And oncoplastic breast surgery involves breast reconstruction. And this can be achieved either with implant or expander-based reconstruction, or by utilizing patient's own body tissues in case of flap reconstruction. Or it can be a combination of both implant and expander-based reconstruction. So these days, White local excision or quadrantectomies are often combined with chest wall perforator flap, such as thoracodorsal artery perforator flap, lateral, anterior, and medial intercostal artery perforator flap, depending on the location of tumor, in order to improve the cosmetic outcome. Now, coming to the imaging modalities, mammogram and ultrasound are the imaging modalities of initial evaluation. Mammogram has got low sensitivity, but it can be used to evaluate for the presence of residual fibroglandular tissue or recurrence in case of implant reconstruction, flap reconstruction. It has got low sensitivity. Eckland views or implant displacement views are useful to increase the image quality by increasing the amount of glandular tissue visualization. Ultrasound has got higher sensitivity and specificity. Major advantage is that it is easily available, but the huge drawback is that it is operator dependent and it is unable to detect subtle findings of early intracapsular rupture. MRI breast is the modality of choice due to high spatial resolution, soft tissue contrast, and high sensitivity and specificity. It is the modality of choice to evaluate post-operative findings, type of surgery, and to evaluate for any recurrence or the complications. The major advantage is that because of special sequences, we can suppress the water signal and enhance silicon and vice versa to evaluate the breast implant. And because of these features, we can accurately detect the presence and extent of complications. So breast implants can be made up of silicone or saline with single lumen, double lumen with silicone gel inner and saline outer, or reverse double lumen with silicone outer and saline inner lumen. So this is an example of silicone single lumen breast implant with bright signal on the silicone sequence and with low signal on water-only silicone suppression sequence. Implants can be placed in subglandular or prepectoral soft space or subpectoral or retropectoral region with classic split muscle sign on the MRI scan. Tissue expanders are temporary inflatable implants. They are placed in a collapsed form and are gradually expanded by saline injection through a port. And this controlled expansion allows surgeon to achieve a desired breast shape or to make space for a permanent implant. In some cases, they can be left as a permanent implant after the expansion process is complete. So soon after the implants are placed, a normal fibrous capsule forms around the implant, which is a physiological process of body towards a foreign object, which is implant in this case. It is clinically impalpable and is radiologically almost imperceptible. We can just see it as a uninterrupted fine black line separating the soft tissues from the implant shell. Small amount of periprostatic fluid is normal. Radial folds are the invaginations of the implant shell into the lumen, and they can have complex appearance mimicking intracapsular rupture, but they should be differentiated by the presence of fluid signal in the outer shell. Now coming to few images showing normal postoperative appearance. So these images are of a patient with bilateral mastectomy Becker expander implant reconstruction after saline injection and expansion has been done. This is the outer silicon lumen with bright signal on silicon sequence. This is the inner saline lumen which has been adequately expanded symmetrically by saline injection. And this is how it looks on a CT scan. And this is the inner tubing and port which is used to gradually inflate the saline lumen. Another patient with right mastectomy with Becker expander implant reconstruction. So this is the outer silicon lumen with bright signal on the silicon sequence. This is the inner saline lumen, which is showing slightly folded appearance because it is only moderately expanded. And this is a small amount of peri-implant fluid, which is normal. Another patient with left mastectomy with Becker expander implant reconstruction. So currently it is only minimally inflated and shows folded and wrinkled. This should not be confused with implant rupture. And this is the metallic port, which is used to for injection of saline and expand the expander. Same patient follow-up MRI scan showed breast implant with saline injection has been done, and the inner lumen shows more rounded appearance. So this patient is a 25-year-old female with right mastectomy. In this case, flap reconstruction has been done. This is the profunda artery perforator flap, which appears intact. And in this patient is incidental finding of left pleural effusion. It is seen anteriorly because MRI breast is done in prone position, and this pleural thickening as well. This is the same fluid which is seen in dependent position of the CT scan. So this was further assessed and found to be tuberculous. Another patient with left breast cancer. So she had white local excision and reverse like a flap reconstruction. This is the flap interface which is intact. And these are the mammogram images which show good symmetric outcome on both sides due to flap reconstruction. Now coming to breast cancer recurrence. Breast cancer recurrence can occur even after mastectomy because small amount of residual fibroglandular parenchyma might be left behind. And the risk factors include size and stage of primary cancer, resection margin, number of lymph nodes involved. Hormonal status such as negative ERPR and HER2 positivity is a risk factor for early recurrence and younger age diagnosis. So the surveillance imaging is done with an aim to early detect the recurrence and to improve the prognosis. The surveillance protocol depends on the amount of residual fibroglandular tissue on the same side, screening requirements of the opposite breast, and overall risk profile of the patient. So cancer recurrence after flap or implant reconstruction can occur in the subcutaneous area, skin, nipple areolar complex, or the chest wall. So now coming to a few cases showing cancer recurrence. These images are of a patient with left breast mastectomy due to high-grade DCIS, ERPR negative. She underwent skin and nipple sparing mastectomy with immediate Becker expander implant reconstruction. So these are the ultrasound images that showed outer silicon lumen with intact interface with the overlying skin. This is the inner saline lumen which has been injected and shows normal expansion. There was no finding on the ultrasound. But on the MRI scan, there was incidental left nipple areolar complex thickening and enhancement. Initially, she underwent partial nipple biopsy that showed DCIS, and afterwards, complete nipple excision was done with negative margins. A companion case showing similar findings. Patient had right mastectomy in 2019 due to high-grade DCIS, ERPR negative with immediate Becker expander reconstruction. So in 2025, on the follow-up MRI scan, she had nipple areolar complex asymmetric thickening, irregularity, ulceration, and enhancement. So she was initially biopsy was done that showed DCIS, and excision showed Paget's disease of the nipple with DCIS. So these CT scan images are of a patient with right mastectomy, with, in this case, latissimus dorsi and flap reconstruction has been done. This is the normal latissimus dorsi on the left side. On the right side, this has been used to create the flap. And this is the fluid in the muscle bed due to early surgical changes. And these are the MRI images that show single lumen silicone implant with bright signal on the silicon sequence. This is the water sequence that shows small radial folds with fluid signal on the outer side. And this is a complex radial fold which appears horizontally oriented through the implant, but it has got fluid signal, so it should not be confused with implant rupture. In the same patient, the dynamic scan demonstrated incidental area of abnormal enhancement in the contralateral side. So this was biopsied and excised with wire localization and was found to be DCIS. So another patient, this patient had history of left mastectomy due to grade 2 IDC with DCIS and had implant reconstruction. And she also had implant symmetrization on the right side. So these images show the importance of Eklund views. This small speculated lesion on the right side is only well visualized on the implant displacement view or Eklund view. So this was further assessed with ultrasound and was found to be a small 8 millimeter grade 1 IDC sitting on the top of the implant. It was biopsied and clipped and afterwards excised. Now coming to implant-related complications. In the early postoperative period, we can have fluid collections such as seroma and hematoma within the capsule or extracapsular, and they often need drainage to relieve the patient's symptoms. Infection is by far the most common cause of morbidity associated with breast implants, and they occur most commonly in the perioperative period and are mostly due to contamination of the implant, surgical instruments, or skin. And often we have other signs of infection such as skin thickening, edema, phlegmonous changes, and complex collections. And these are managed with antimicrobial treatment and drainage of collections. So a case to illustrate the infection. This patient is a young patient, 27-year-old, BRCA positive, left breast cancer. She had bilateral mastectomy with Becker expander implant reconstruction. So, and she presented with new onset left breast swelling. So this is the normal right breast. This is the outer silicon lumen with intact interface with the overlying skin. And this is the inner saline lumen, which is not yet inflated and shows folded appearance. On the left side, this is the expander, which is collapsed and displaced, and this is the peri-implant heterogeneous collection with internal echoes, and there's increased echogenicity of the surrounding soft tissues representing inflammation. Afterwards, she also had MRI scan. So on MRI scan, we can see collapsed bilateral expanders. This is the minimal fluid in the saline lumen, and this is the outer silicon lumen on the right side, which is the normal side. On the left side, we can see this is the partially expanded Becker expander, and there's a huge peri-implant collection, which is causing displacement of the port. This is the port, and this is the peri-implant collection, which is resulting in left breast enlargement, and there's thickening and enhancement of the left breast capsule. So this patient was managed conservatively with a multidisciplinary teamwork between ID team with continuous inflammatory markers correlation and ultrasound follow-up that showed interval improvement in the peri-implant collection. And afterwards, she had left breast implant capsulotomy, port removal, and intraoperative symmetrization with saline infusion. Late complications include delayed peri-implant fluid, which is always abnormal. So delayed peri-implant fluid is mostly due to inflammation secondary to the implant shell, and it needs percutaneous fluid aspiration to relieve the symptoms and also to evaluate for breast implant lymphoma. We often do MRI scan to evaluate for any soft tissue masses or capsular mass. So this case is of a patient with bilateral breast augmentation 7 years ago. She presented initially with a small nodule. This was biopsied and excised and was found to be low-grade DCIS with intraductal papilloma. The next year, she presented with this left breast swelling. Initially, mammograms were done that showed peri-implant thickening and increased density. Ultrasound was done that showed this peri-implant collection with internal echoes, septations, and heterogeneity suggestive of organized collection. And also MRI scan was done. So this MRI scan shows this collection within the implant capsule with displacement of the implant anteriorly. And there is enlargement of the left breast due to this collection with thickening and enhancement of the implant capsule. There was no soft tissue mass on MRI scan. And she underwent left breast implant removal with cavity washout and was found to have turbid fluid in the cavity, thickened capsule, but there was no mass or implant rupture. And histopathology also showed inflamed fibrous capsule, no malignancy. Now coming to breast implant-associated anaplastic large cell lymphoma, it is a very rare form of lymphoma which is associated with breast implant capsule, and it is due to the inflammation of the implant shell, and it affects 1 in 300,000 breast implant cases, with average time of 8 to 10 years after the implants have been parked. Patients most commonly present with breast enlargement, which is mostly due to effusion, and in some cases due to presence of lump or a combination of both. So in patients who present with peri-implant effusion, it is recommended to aspirate as much as possible the effusion and to send it for CD30 staining, which is characteristically positive in these patients. This is a case of a patient which is not a breast cancer patient, but just to illustrate the signs of the features of breast implant lymphoma. So patient had history of bilateral breast augmentation 19 years ago, presented with a lump in left breast upper inner quadrant. Initially, mammograms were done, including the Eklund views, which were normal because the lump was behind the implant. And this is the ultrasound image that showed the heterogeneous mass behind the implant edge on the top of chest wall. This was a technically difficult biopsy, but it showed abnormal lymphocytes with CD30 positive staining, suggestive of breast implant associated lymphoma. Further MRI scan was done that showed this heterogeneous mass, and PET scan also demonstrated increased FDG uptake. So in patients who have only peri-implant effusion, they are managed with bilateral implant removal with intact capsule removal and block capsulotomy with excellent prognosis. In other patients with advanced disease, such as in this patient with soft tissue mass or with distant metastasis, they initially managed with chemotherapy followed by implant removal. So this patient also underwent chemotherapy with complete radiological response, and afterwards surgery was done with bilateral capsulotomy with no residual disease on histopathology. The normal fibrous capsule is a normal physiological process, but sometimes due to excessive scarring, capsular contracture occurs, which results in patient's pain, implant deformity. And on MRI scan, we can see abnormal rounded morphology of the implant with increased capsular thickening and enhancement. Implant rupture is one of the key delayed complications related to implants, and the incidence increases with the time the implants have been placed. For example, like after 10 years, 10% of the implants have ruptured. After 20 years, around most of the implants have undergone rupture. Intracapsular rupture involves compromise of the implant shell with silicon leak that does not extend beyond the intact capsule. And extracapsular rupture involves tear of both shell and capsule with macroscopic silicon leak through the fibrous capsule into the soft tissues. The implant rupture can further be characterized on the basis of implant collapse. In early uncollapsed rupture, the silicon migration occurs through the shell and occupies the vacant spaces adjacent to the capsule. This is the normal, and it is typically along the radial folds. This is the normal radial fold with fluid signal on the outer side. When silicon occupies this space, it gives rise to teardrop sign when the two membranes are in contact, or the keyhole sign when they stay apart. These are the signs of early uncollapsed rupture. So as the rupture progresses, the silicon migration continues to occur behind the fibrous capsule and between the torn membranes and gives rise to subcapsular rinds. And in a frankly advanced collapse rupture, the torn membranes are floating within the implant shell, implant lumen, giving rise to Linguini sign, which is the MRI counterpart of step-ladder sign on ultrasound. So these MRI images, these are again not of a breast cancer patient, but just to illustrate the signs of intracapsular rupture. Patient had history of bilateral breast augmentation 15 years ago, and these are the single lumen silicon implants. On the silicon sequence, we can see teardrop sign and keyhole sign. And at another level, we can see this Linguini sign in the lower slice. And on the fluid sensitive sequence, we can see this water droplet sign, the presence of fluid signal within the silicon on the water sequence. On its own, this is not a reliable sign of implant rupture, but we should be able to see other signs like in this patient to confirm the intracapsular rupture. So this is itself more considered as a sign of implant degradation. Extracapsular rupture involves rupture of the implant capsule with presence of extracapsular silicon, like in this case, and it can be seen as a snowstorm sign on ultrasound. For the clinical history that we are dealing with breast expander or implant is very important. Like in this patient has history of right breast mastectomy with double lumen Becker expander implant reconstruction, and after saline inflation has been done. But in this case, we cannot see any saline filled lumen on the water sequence. And on the silicon sequence, the membranes, we can see some irregular membranes. So this patient had a history of right expander port removal before this MRI scan. And these are the previous MRI images where we can see regular expanded appearance of the inner lumen. So the procedure of port removal probably led to saline leakage and an implant collapse. So the correct clinical history and discussion with surgeon if needed is very important to avoid an incorrect diagnosis of implant rupture. Silicon bleed is a phenomena when silicon transudation occurs through an intact capsule and shell, and it is due to the inherent affinity of silicon for the silicon elastomere. And this silicon can be taken up by the lymph nodes, giving rise to silicon granuloma, and it should not be confused with extracapsular rupture as the implant capsule is intact. So these images, this is a patient with previous history of right breast cancer. She had bilateral mastectomy with Becker expander implant reconstruction in 2007. And in 2024, she presented with a new left lateral chest wall mass. This was initially assessed with ultrasound and CT scan, and with classic snowstorm sign on the ultrasound. Because it was a new clinical abnormality, this was biopsied and it showed dense chronic inflammation. Afterwards, she also had MRI scan to assess for any associated soft tissue. So these are the implant protocol images that show bilateral double lumen expander implants with adequate inflation of the inner saline lumen. There is no extracapsular rupture associated mass in this patient. And this is the site of clinical concern on the left lateral wall, and similar nodule was seen in the right internal memory region. So these nodules follow the signal of silicon on the silicon sequence and are suggestive of silicon adenopathy secondary to silicon gel bleed in this case, and there is no implant rupture. Now to summarize, we need to be aware of the wide spectrum of normal appearance and variations of the reconstructed breast in order to face confidently the challenging and complex cases. And MRI is by far the most accurate imaging modality when it comes to the implant integrity, because with the help of special sequences, we can detect cancer recurrence, early and subtle signs of implant rupture, and implant-related complications, which would be difficult to detect with other imaging modalities. Thank you.
Thank you, Dr. Sarah. So for the last talk of this session, the topic is malignancy or not, transvaginal ultrasound elastography as a non-invasive gatekeeper. For this, I'd like to invite Dr. Saman Chaudhary. She's an associate professor and head of radiology at Gangaram Hospital with a subspecialty in women's imaging. She's also the vice president of National Breast Radiological Society of Pakistan. Dr. Saman, welcome.
Thank you so much. Bismillahirrahmanirrahim. Assalamu alaikum and a very good afternoon to all of you.
Okay, written.
Well, first of all, I'd like to congratulate the entire team of Shaukat Khanum for putting up this amazing activity every year, especially the radiology department for having us here and giving us this opportunity to come together and learn new things. I'll be discussing a very important topic, which is endometrial cancer. We have, I think, talked enough about the breast cancer. Let's talk about endometrial cancer now, which is one of the commonest gynecological malignancy in the Western world, and its incidence is constantly rising. And it has observed that incidence has increased for over 130% in last 30 years, and it continues to rise. So let's see that how at a government teaching hospital, we are trying to play our role to manage this cancer. So it's a very important pathology which we come across day in, day out. And the problem is that not just the cancer, but the other benign endometrial pathologies, they also have similar presentations. Like most of these patients, they present with uterine bleeding, right? Or maybe with the pain or non-specific symptoms like that. So this basically comes out to be challenging that you cannot differentiate these patients on just on clinical presentation. So you have to rely on investigations and imagings. So most commonly, these are the few investigations which we have. First of all, the patient is assessed clinically by detailed bleeding history, detailed reproductive history, family history, the medical history, and the genetic history. And the next step, which is the investigation, the first line of investigation is mostly an ultrasound, which is a transvaginal scan. Then we have hysteroscopy, we have DNCs, we have blood or urine analysis, and we have cervical fluid analysis. So mostly we are rotating around these investigations. As far as imaging is concerned, a transvaginal scan is the first modality in case of a patient with uterine bleeding. And it basically tells us or gives us information about the endometrial thickness and helps us triage the patient for the biopsy. Once the patient has been diagnosed with a cancer, the local staging is done with MRI most commonly, which is the gold standard, and the distant metastatic workup is done with PET-CT. But the issue is that these routine investigations, they have their own limitations. Like in TVS, we deal with poor specificity, although morphology is good. MR is costly, especially if you talk about a government hospital where the patients are not very affording. Histopathology is obviously gold standard, but it's an invasive procedure. So where we are now? I mean, is this as far as we can go with the imaging? Fortunately, the story does not end here. The answer is no. There have been, over the recent years, there have been great advancements in new techniques and new software, especially in the ultrasound. One of them is elastography. And this is what I'll be discussing today, that how in transvaginal ultrasound, the elastography played its role in detection and characterization of benign and malignant endometrial pathologies. So the very first question that arises in our mind is that what elastography is. Now we know that whenever a patient comes to us with a mass or with a large swelling, what we do first? I mean, before any investigation, we palpate the mass or we palpate the swelling. Why so? Because we know by default that a mass or a malignant mass, malignancy is going to be hard and a benign pathology is going to be soft, right? So this principle that a pathological process changes the stiffness value of the involved tissue is basically used by elastography. So elastography is basically, it's basically palpation by imaging. And it measures the change in the stiffness of the abnormal tissue relative to the normal tissue and gives us some quantitative values where we can have reliable results. Now, in case of endometrial pathologies, what is the role of elastography? We know that there have been enough data and a lot of publications on the use of elastography in the assessment of tumors of breast, prostate, and liver. However, the publications or the literature on the use of this technique in gynecological cancers, it's not very much. There are very few studies done on this particular case. And then there is a difference in elastography of endometrial pathologies, which is that the endometrium, it changes its stiffness during the cycle. Like you have different stiffness of a normal endometrium during the cyclical phases of the menstrual cycle. So that has to be kept in mind as well. So just to give you an overview that how in different non-pregnant and pregnancy conditions, this stiffness changes. The conditions written in red are those in which the stiffness increases. Now, when we talk about the increase or decrease in the stiffness, please keep in mind that we are talking about in reference to the normal myometrial stiffness, right? So in endometrial cancers, the stiffness increases. In fibroids, it increases. And in cervical cancers, the stiffness increases. And in various cervical pathologies in a pregnant patient. In case of polyps, the stiffness decreases. And for adenomyosis and for atypical endometrial hyperplasia, the stiffness, it varies. Like we get variable results, right? Now, elastography is of two types. One is strain or compression elastography, and the other is shear wave elastography. Now, the name indicates that strain elastography or compression elastography has something to do with the strain or compression. And shear wave elastography basically measures the propagation speed of some shear waves generated by specialized ultrasound beams, right? So I'll quickly go through that how we perform these and how we differentiate these. In strain elastography, we apply an external compression and we see that how two different types of tissues, the normal and abnormal, they respond to that. The softer tissue will deform more and the harder tissue will deform less in response to this strain or this compression. And this is this relative stiffness, which we then measure with the help of strain elastography. As far as shear elastography is concerned, the propagation speed of these waves, this is measured directly in kilopascals or meters per second, and that is what we interpret in our studies. Now, for endometrial pathologies, the question arises that how do we apply elastography? Either we do the scans transabdominally or we do it transvaginally. Now, as for the grayscale imaging, obviously the simple answer is transvaginal, obviously because of the proximity, because of high resolution and better visualization. For transabdominal imaging, there is a larger window, there is poor penetration, and there is air in the acoustic pathway. So results are not that good. So we go for transvaginal elastography. I'll briefly explain how we do these and how we interpret the images along with showing you a few clinical cases. For strain elastography or shear, what we do is that we select the option of elasto or shear wave, whatever we're doing from our control panel of our ultrasound unit. And for strain elastography, this is the first image we get. This is a large box which we can change in the size. With this color-coded image, a semi-transparent image overlaying over the beam mode ultrasound, this is called elastogram. Once we get this, we start applying soft, regular compressions. And this bar, green bar on the left side, show us that we have applied adequate compressions. Once we have done this image, a complete image, we start applying ROIs. Usually we apply 3 ROIs on the endometrium or the thickened endometrium or abnormality we are going to, which is under question. And a reference ROI is placed over myometrium. And this then calculates us certain values, and then that is how we interpret the images. Now, there are two methods of interpreting strain elastography images. One is by the color-coded image we get, which is called elastogram, and other one is the strain ratio, which compares the strain in the abnormal tissue and the normal tissue, and it gives us a ratio. So this is the color map, the elastogram. The elastogram, basically, the color varies from blue to red. The blue one is for the harder or for the stiff tissues. If the stiffness comes higher, this points towards a malignant pathological process. And if it's red, it's a softer or a lesser stiff tissue. And it's in comparison to the normal myometrium. But this can vary. This can be vice versa, depending upon which vendor unit you are using, all right? Next is the strain ratio, which is the relative measurement comparing the stiffness of a region of interest and a reference tissue, which in this case is the myometrium. A higher strain ratio indicates a malignant process, a stiff tissue, and a lower strain ratio suggests benign disease or a soft tissue. I'll just show you a few examples of the elastogram. This is a normal image in which you can see that a normal endometrium appears yellow to green, is softer as compared to the surrounding blue myometrium, right? In this case, you can see that there is blue line in between the endometrium. There was IUCD, which was hard, which has higher stiffness. So it appeared blue, surrounded by normal soft endometrium and then by the stiff blue myometrium. Now, in this case, we can see that there is widening of the junction zone, some cystic areas. This appeared yellow to green, that is softer on the elastogram as compared to the surrounding stiff blue myometrium. This was again a case of, I hope you can see, the focal adenomyoma, which is softer as compared to the surrounding myometrium. So adenomyosis, in adenomyosis, the stiffness varies, but most of the times it's towards the lower side. Next is a case of fibroid. You can see that fibroid is more bluish, darker blue as compared to the surrounding myometrium. In fibroid, the stiffness is higher as compared to the surrounding myometrium because of its composition. This is a case of polyp. You can see that is focal thickening, focal echogenicity towards the fundal region, which appears yellow, on the elastogram. It's not working. On the, sorry. Okay, it appears yellow on the elastogram as compared to surrounding myometrium. And this was a case of large polyp. Again, it appears less stiffness on the elastogram. Now, to show you a few examples of how we calculate strain ratio, after getting these ROIs, the equipment automatically calculates the strain ratio. In this particular case, you can see that on elastogram, the myometrium is blue. It's dark blue, almost comparable to the surrounding myometrium. The strain ratio came out to be 11.5, which is on a higher side. So higher strain ratio suggests stiff tissue and a malignant disease. And a low strain ratio, like in this case, you can see that endometrium is light blue. It was a 60-year female with PV bleeding with endometrial thickening, but the strain ratio turned out to be 1.3, and the biopsy proved to be, on biopsy turned out to be endometrial hyperplasia. This is another case of endometrial carcinoma, in which there is significant endometrial thickening, heterogeneous with internal cystic areas, blue on elastogram, and strain ratio was 13.5. Suspicion was of endometrial cancer, and biopsy proved that finding. For shear wave elastography, we simply get a value in kilopascals or meters per second. A higher kilopascal value indicates more stiff tissue, and a lower kilopascal value indicates less stiff tissue or a benign disease. For example, in this case, on left side, you see strain images, and on the right side, you see shear wave elastography images. On grayscale images, you can see that there is focal thickening in the endometrium. Thank you. In the endometrium, which was green on elastogram. The strain ratio came out to be 0.6, which is quite lower. And on shear wave elastography, the value turned out to be 12, which is again lower. This was suspected to be a polyp and confirmed on shear wave and strain elastography to have low strain ratio and low shear wave values. Okay, this was a case with irregular thickening of the endometrium. We can see that it's clearly invading into the myometrium. The shear wave value turned out to be 53 kilopascals, which is significantly higher as compared to the one in the previous case. This was proved to be endometrial cancer. Sorry, I don't have grayscale image for this, but if you can appreciate, there is some widening of the junctional zone, some cystic areas. This was a suspected case of adenomyosis. We did shear wave elastography, and the value turned out to be 7 kilopascals, which is again on the lower side. It was confirmed on subsequent MRI. Another patient with the postmenopausal bleeding, significant thickened endometrium with cystic areas, soft tissue component. Again, we did shear wave elastography. The value in this case surprisingly turned out to be 25. However, since this was heterogeneous, so that obviously affected this values, and it was confirmed on MRI and histopathology to be a case of endometrial cancer. Again, another patient with cancer, the value was 54. Sorry, this was a patient with fibroid, focal area, strain wave, shear wave elastography was 45. So for a fibroid, we have higher stiffness value, but for hyperplasias or for polyps, we have lower stiffness values. And for the cancers, again, I mean, this has a higher value, but not that high as the cancer. So we get some idea that what kind of pathology is going on, although these are the typical cases I've shown you. But most of the times we come across the cases, especially with the endometrial thickening, that we cannot clearly say just based on the morphology that what actually is going on, as most of these patients are presenting with PV bleeding. So in the clinical context, what you have to do is that we cannot just rely on strain wave or shear wave elastography findings. We have to interpret our B-scale images, the routine transvaginal ultrasounds. We have to compare to the reference values, and we have to look for specific patterns as we have discussed, and we have to be aware of what kind of technology we are using. So there's been a literature view of a meta-analysis of some studies went through this, and the results I came across were that it adds quantitative stiffness metrics to conventional imaging. So it's basically adds number to what morphological findings we are currently relying on. So obviously it adds on the accuracy, and it shows promising results for the differentiation of benign and malignant pathologies, and it has to be used as an adjunct and not yet a replacement for the histology or gold standard imaging, obviously. It obviously has its own limitation. Just like other ultrasounds, it's operator dependent. We still have small scale studies. We don't have vast studies on this particular case. And we have overlapping stiffness values, like in fibroids, we have higher values. And adenomyosis, sometimes we also come across higher values. And then there is limited penetration in obese patients. And the cyclical endometrial changes is also one factor which we have to consider while doing these elastography studies. So what we can do is we have to perform large center studies. We started doing this in the start of this year, and we have to combine shear wave and strain with the routine studies, and we have to investigate the utility of this particular technique. I think in the post-treatment response cases, I think it would be helpful in that particular scenario as well. And we also have to keep in mind, and we have to explore the effects of menstrual cycles on these findings. So it's a promising adjunct and has potential role in early detection and the differentiation of benign and malignant pathologies. But we still need more robust studies and larger data. Thank you.
जी थैंक यू वेरी मच अभी मेरे ख्याल में 10 से 15 मिनट हैं so before going into question and answer session I would like to thank all the speakers for the wonderful talks. These were really knowledgeable and really helpful in updating our knowledge. उससे ज़्यादा जो ज़रूरी है कि आप लोगों ने हमारा टाइम निकाला हमारे लिए और रेडियोलॉजी डिपार्टमेंट की तरफ से आप सबका बहुत शुक्रिया. Also, I want to take the opportunity and ask Dr. Shahid Waheed to say a few words क्योंकि सर कभी कभी काबू आते हैं तो इनसे हम कहेंगे कि कुछ हमें जो है ना अपने कीमती अल्फाज से नवाजें प्लीज़.
First of all, I would like to thank Shaukat Khanum, organizing committee, Dr. Kashif, Dr. Adis, and the speakers. Wonderful lectures I have attended, and especially Dr. Sarfraz, Dr. Ramzan, Dr. Sara, and Dr. Saman updating us about the radiology. जिस एज से मैं बिलोंग करता हूँ, I have seen the transformation of radiology just from just simple X-rays to ultrasound. And even if I see the ultrasound, there are so many softwares, as Dr. Saman has given us the demonstration of how to apply the elastography in different diseases processes. Like the Dr. Sara also gave us the application of different modalities, not just to see the effect of the surgery, what can be the complication, how the implants can be assessed, and what are the complications in the implants, and what are the complications we can see in the reconstructed breast. And one more important, which is very much emerging, is the intervention radiology, just minimal to maximum intervention and minimal precisional intervention, as Dr. Ramzan has given us the demonstration of different procedure like embolization in the fibroids, adenomyosis, and Dr. Sarfraz gave us some implantation of the radioactive seeds, wires, and roll and magnetic belts. So thank you very much for giving us some rather so much knowledge for these pathologies. Thank you very much.
If anybody want to ask questions, the speakers are here and we have last few minutes. So if anybody want to ask any question or want to discuss anything, it's their time now. Thank you. I'd like to thank Dr. Arkham as well. He managed, he was doing dual function actually. He was doing as a modulator and also controlling the online session while sitting over there. So thank you, Dr. Arkham as well. Thank you. Thank you, everybody. Thank you for your time. Assalamu alaikum. It's a question.
First of all, I would like to thank all the presenters. My question is with Dr. Ramzan. For uterine fibroid embolization, what size of particles you prefer to use? And the second question is that for fibroid embolization, in which hypogastric block is technically not possible, how you manage the pain?
Thank you, Usman. Actually, we started with small particle in the past, but over the time we have come across that the larger particle has a similar effect. Currently, I'm using anything above 700 and 900. The reason is because there is no difference between using small particles and the large particle. At the end, the results are the same. The other issue is in large particles, because there is communication between the uterine arteries and there is a supply to the ovaries. So the large particle usually don't reflux, so you will not end up having like ovarian insufficiency syndrome. And the other thing is the cost. Definitely using less particle is you can say is a bit cheaper. Hypogastric block, if you can't do that, I have tried, and we initially did a pilot study. At the end of the procedure, mix some of the local like xylocaine and inject. That's really effective. But if you can do the hypogastric block, that's really good actually. But if keep in mind, don't inject the this xylocaine to start with, because it will cause the spasm and you will not be able to inject actually. So at the end, if you inject, the patient usually respond well.
Khalid Javed, thank you, sir. My question is about fertility preservation in case of uterine artery embolization, particularly in recent data presented in CVIR. As in our culture, it is said fertility is not spared, rather compromised in UFE. And in case of fibroid embolization, our patients suffered more problems like abnormal placentation and anomalies and prematurity.
Actually, to start with, when the fibroid embolization was started, we are offering the patients, those who have completed their family or they don't want to have their family actually, because of we don't have at that time the data for the like it's a safe or unsafe. But over the time, new and new, because the fibroid embolization is taking over now. Now, it is taken as a safe, as you said, in larger tumors, the abnormalities like placenta, abnormal implantation and this kind of stuff is still there. We have to go further a long way. But in cases of like, if there's a single fibroid or a couple of fibroids, I personally prefer to do ablation actually. And ablation where you see it's close to the endometrium, we can put a drain or tube in or catheter in, and we can run the cell line just to keep the temperature low to avoid the endometrial. But still, we need further data to confirm, but in our settings, what I have seen over last 10 years, the young patients which I did, they really did well, but still we need a lot of data to confirm what exactly the outcomes of fertility will be. But we're doing like in these days we are offering like even for the infertility, if the fibroid are the cause of infertility.
Thank you. Another question from Dr. Saman. Very good presentation to highlighting some newer applications of elastography. My question is about preventive aspects of elastography. As we can see in other countries, there is a lot of stress over elastography in preventive aspects.
You mean screening? For screening purposes. Yes, I think basically that's the main idea, to detect the pathologies earlier, as you can pick up most likely. I mean, you need larger studies for that particularly, but the change in stiffness starts as soon as the pathological process starts. And if you can pick it earlier, especially with the help of elastography, it can be really helpful. And that is one area we can also start exploring along with this. But the problem with our setup is that patients only come to us when they have symptoms. We are still struggling with the breast screening programs. So, but yes, we can try for that, and we can start evaluating patients for that as well.
My question is for Dr. Ramzan. Since endometriomas are so common, what has your experience been regarding recurrence rate for those? And another smaller question that you mentioned radiofrequency ablation for thyroid lesions. Have you have any experience for ablating small thyroid lesions for which the surgeon doesn't like to go because it's a small residual foci of disease?
Actually, the first was the endometrioma. Is that correct?
Yes.
Sorry. So actually, patients don't come to us primarily for the endometrioma. Usually, these patients are those patients who had already surgeries and this kind of stuff. And when they're looking around, they can find, I think, thanks to AI, because when you put something in, that gives you 100 options, and then the people start looking around. So endometrioma, these are well-defined lesions I usually take, which are accessible percutaneously or pervaginally. And I've done up till now 9 or 10 cases. And we have done like only 1 or 2 microwave ablations. And for the microwave, keep in mind, there's a certain size you can burn actually. That should not be more than 4 centimeter actually, because you have to burn the endometrial lining. But the sclerotherapy using alcohol is really good, especially if you can aspirate the fluid, and if the alcohol is going. There is, I think one patient had the recurrent symptoms, which we repeated actually. And this is what exactly the endometrioma is. दूसरा क्या था?
Regarding residual thyroid disease, small volume.
Actually, the thyroid is up till now for the benign lesions. It's not recommended for any cancers up till now. And the benign lesions is for cosmetic reasons, actually. Even if you don't treat benign lesions, that's fine. But if something is sitting here, and with you can say all the things, the people doesn't want any scar on the neck, actually. That's why the thyroid ablation is coming in and in. But we haven't done any cancer up till now. The people have done few, but it's not really recommended up till now, and there's no data about that.
Right. Thank you.
Parathyroid, you can do it. And even we were, I have done, especially in cases with the tertiary hyperparathyroidism, where the renal failure patient had the parathyroid hypertrophy, and they are autonomous, they are excreting everything and eating away the bones. So I started with the alcohol ablation. To be very careful here, because you have to inject a lot of saline to get away from the recurrent laryngeal nerve. And I started with alcohol, but we have done few cases of parathyroid, even the ablation. But it should be, but be careful about the recurrent laryngeal nerve.
Assalamu alaikum. My question to Dr. Ramzan. Sir, are there any possible interventional pain management treatments in patients with osteoarthritis? As you mentioned about palliative care.
Yes, the MSK intervention is, I think, coming in. You can, like in joints, people that are doing like injection, steroid injection and local injections anywhere. But with the time, I think for the knee joint pain, especially the patients, those who can't go for knee replacement surgeries and they have comorbidities, the genicular artery embolization is well-known entity now. And even for the frozen shoulder and for the, you can say the plantar things like fasciitis, the people have done embolization and they work really well. Frozen shoulder, for the knee joint, actually, it's really effective. The embolization of genicular artery, it's really effective, and it's, I think, it's in literature everywhere.
So in Pakistan, which hospitals
भेजे हमारे
are?
पास PKLI में. We have done it.
Okay. And what is the success ratio?
Success, we have done only 2 cases up till now.
Okay.
And they are fine, actually. They don't need painkillers, but it takes some time, like a few weeks, like 4 to 6 weeks to get rid of all the painkillers, actually.
Okay.
We don't know what the long-term results are, but everywhere the MSK embolization is the main topic wherever you go, like abroad in any of the conference. So something is happening.
Okay. Thank you so much.
Any further questions? चलिए ठीक है. Thank you very much. बहुत शुक्रिया. Thank you all.